Hello. Our article looked at shoulder external rotator eccentric training versus general shoulder exercise for subacromial pain syndrome. The study was conducted in 2017 and was a randomized controlled trial by Chaconis et al. The study was examining eccentric external rotation treatment effectiveness for subacromial pain syndrome compared to the control exercise group. The interventions were delivered for 6 weeks and comparison results were collected at weeks 3, 6, and at 6 months post-intervention. The level of evidence of the study was rated as a 2B. The patient population consisted of 48 individuals. There was initially 71 participants, however 7 were excluded and 16 did not meet the inclusion criteria. The results of the study demonstrated that eccentric external rotation program was superior to a general training program at increasing strength and function and decreasing pain over a 6-month period. The results demonstrated a significant difference in favor of the experimental group for the self-reported function measure WORC and the NPRS decrease in pain and in external rotation and abduction strength compared to the control group. The effect size of this study was statistically analyzed and rated at 0.40. The statistical power set was also calculated and it was determined to be 0.80. With this information, it was determined that approximately 48 participants in the study were needed for significance. The effect size of 0.40 indicates that any change noted is small enough that it cannot be observed with the naked eye. Now to Gio with sports.
Parameters of variability. There was no parameter for variability of injury time. The study states that the patients enrolled had shoulder dysfunction greater than 3 months. However, there was no cap on the length of time for the injury, meaning someone could have had it for 3 months while someone else could have had it for a year. Golly jeepers, that's a big difference. The study also states that a patient must be positive 3 out of 6 special tests, but does not subgroup the patients depending if they had tested positive for 3 tests or if they had tested positive for 6 tests. This variability would affect the starting point for each patient. Threats to internal validity. The researcher who conducted the inclusion study will also be the one who is conducting the measurements. Although he does not know which group they are allocated to, this aspect of non-blinding selection may contain slight levels of bias. There was also a high level of attrition in this study. 11 participants dropped out, which left only 75% of the original group remaining. The determination of inclusion was based on special tests instead of MRI, could have led to a decrease in internal validity with patients who had a false positive result being included in the study. Threats to external validity. The relatively small sample size from the study can result in a decreased ability to generalize the results to the general public. The participants were taken from the small community, which decreases the generalizability of the study because these participants were most likely in similar circumstances with relatively similar history. A better method would have been to draw the participants from a variety of communities.
Alright, so now let's look at the study strengths. So this study demonstrated a lot of detail in its description of the outcome measurements, data collection, and treatment parameters, which makes the reproducibility of the study more likely. The researchers in this study also used instruments and equipment that had higher levels of reliability. Another study strength comes from the experimental design where the independent variable is only a single exercise difference, and this makes controlling the variables easier. Study weaknesses were the inclusion criteria included patients demonstrating subacromial impingement syndrome as diagnosed via special test but not MRI. This could have resulted in false positives and could have decreased validity of the test. Another weakness comes with the choice of what generalized exercise treatment consisted of. Could different exercises have affected the control group at all? The small sample size also is a limitation to this study as it may decrease the ability to generalize the findings to the general public. So finally, what does this study mean to us as a clinician? As clinicians, the study gives us another tool to utilize with our patients who are suffering from the subacromial pain syndrome, and it gives us tangible data that demonstrates that eccentric training programs can be more effective in treating subacromial pain syndrome than active range of motion alone. Thank you.